appearing as an individual, we have Elena Hishka, Associate Professor and Canada Research Chair in Health Systems Innovation at the School of Public Health, University of Alberta. Dr. Meldon Kahan, Associate Professor, Department of Family Medicine, University of Toronto. Bohdana Nozick, Professor at St. Paul's Hospital Canfar Chair in HIV/AIDS Research, Faculty of Health Sciences, Simon Fraser University. And Dr. Marie-Ève Goyer, physician, Clinical and Organizational Support Team in Addiction and Homelessness. We are now going to hear the opening statement of our witnesses. Each witness will have 5 minutes for a statement. We will begin with Dr. Hishka, then Dr. Kahan, then Dr. Nozick, and then Dr. Goyer. We will now begin the meeting. Go ahead. Dr. Hishka.
Thank you. Thank you for the opportunity to appear today. My name is Elaine Hishka, and I am a Canada Research Chair in Health Systems Innovation and an Associate Professor at the University of Alberta School of Public Health. I'm joining today from Edmonton on Treaty 6 territory, traditional lands of First Nations and Métis people. My opening remarks outline the current situation in Alberta, how we got here, and where we need to go provincially and nationally to achieve sustained reductions in drug-related morbidity and mortality. 2023 will be the worst year on record for opioid poisoning deaths in Alberta. Between January and November, we lost 5 people per day, a total of 1,706 people to fatal opioid poisoning. This annual death count, though still incomplete, is nearly 19 times higher than that observed at the height of the prescription opioid crisis in 2011, when 91 Albertans died from opioid overdose. The situation is so severe, it is contributing to declines in population life expectancy. What accounts for the substantial increase in mortality? The preponderance of evidence indicates that the exponential increase in deaths in Alberta is the result of fundamental and presumably permanent shifts in the illegal drug supply, which have made using drugs much more dangerous than ever before. It is not the result of a significant increase in the prevalence of addiction or opioid use disorder. We currently have no data showing that there has been a huge increase in the number of people who have developed opioid use disorder or addiction in Alberta since 2011. Instead, well-intended efforts to reduce prescription opioid use beginning in 2012 led to a rapid reduction in prescribing and a 50% reduction in the total population flow of prescription opioids by 2018. Unfortunately, the death rate did not decline. It surged as the illegal drug market moved to fill this gap with highly toxic, clandestinely produced novel synthetic opioids. Complicating the situation further are increasing rates of stimulant co-use and contamination of opioid products with benzodiazepines and other sedatives. We have now lost 10,160 Albertans to toxic drugs. To put this number in perspective, 3,861 more people have died in this crisis than have died from COVID-19 in Alberta. Most people dying are young and middle-aged. Many are First Nations people who, as a result of colonization, racism, and discrimination, die at 7 times the rate than non-First Nations people in Alberta, contributing to a 7-year decline in their life expectancy between 2015 and 2021 alone. The potential years of life lost and the impacts on surviving children, parents, families, friends, and communities are enormous, and they are devastating. Reversing this trend will require an evidence-informed public health response that we have yet to see anywhere in Canada. COVID-19 demonstrated how coordinated and well-resourced public health efforts can achieve rapid advances in science and avert substantial morbidity and mortality over time. We need a similar societal response to toxic drugs to save lives, promote health equity, reduce pressure on health systems, and avert billions of dollars in lost economic productivity attributable to toxic drug deaths. Critical components of this response include estimating the number of Canadians at risk for drug poisoning, then using this data to optimize and expand proven interventions like opioid agonist treatment and supervised consumption to ensure we meet needs across the population. It also includes acknowledging the reality that the majority of people at risk for drug poisoning in Canada do not meet criteria for opioid use disorder and will not routinely seek health care for drug use. This means continuing to trial novel models of prescribed and non-prescribed safer supply with the aim of reducing exposure to toxic drugs. Equally important, we must address the underlying factors that increase vulnerability to drug-related harm. This requires concerted efforts to improve management of chronic pain and mental health conditions, improve health and social status of Indigenous peoples, and reduce rates of housing insecurity and poverty nationally. Finally, we need to invest in implementing and evaluating community-wide universal prevention programs for children, youth, and families, which have strong potential to reduce rates of early adolescent drug use and would pay dividends in the many realms of social life. Thank you again for the invitation to appear today and for your thoughtful study of this issue.
Merci, Dr. Iska.
Thank you very much, Dr. Heska. Currently, there is a vote in the House, and so I'm going to ask colleagues whether they want to continue with the meeting or whether they want to suspend in order to vote.
Merci, Monsieur le Président.
Thank you very much, Chair. I would suggest that we hear the other witnesses and then take a pause, because I think that would give us enough time. Does everyone agree? Okay. We'll continue with our witnesses. Next, we have... sorry?
Alors, le prochain...
So the next witness is Dr. Kahan. Sorry, Mr. Kitchen, something to say?
Thank you. Just point of clarification. We had 3 more witnesses, correct? That are going to be speaking. That's 15 minutes, and we have 20 minutes.
Oui.
Or 30-minute bells, right? Okay.
Oui. Oui, Monsieur John.
Can we agree to just, when we break, to vote here from our house? Yeah, okay, good. Thank you.
Sorry, but I believe I should be in the House.
Donc, on va poursuivre.
So we'll continue with the witnesses, and then we will suspend for the vote.
Alors,
So, Dr. Kahan, you have 5 minutes.
Thank you for giving me the opportunity to speak on the opiate crisis. My talk will focus on opiate agonist treatment, or OAT, and safer supply. Opiate agonist medications, including methadone, buprenorphine, and slow-release oral morphine, are usually dispensed under supervision at the pharmacy. Take-home doses are given when the patient reduces high-risk opiate use. All 4 medications are long-acting potent opiates. At the right dose, they relieve withdrawal symptoms and cravings for a full 24 hours. Research has shown that opiate agonist therapy reduces opiate use, injection-related infections, and overdose death, even among people who use fentanyl. Unfortunately, only a minority of fentanyl users are engaged in opiate agonist treatment, and retention rates may be declining. There are several strategies to improve access to OAT and to improve treatment retention rates. Opiate agonist treatment should be available on-site and immediately to patients in the emergency department or hospital, withdrawal management services, and rapid access clinics. In order to accomplish this, emergency departments and hospitals should have on-site addiction services. Opiate agonist treatment should be available to people regardless of where they live. This can be accomplished through virtual care. The Alberta Virtual Opiate Dependency Program is highly successful and a model for the rest of the country. There is a need to pilot and evaluate innovative medication protocols that provide quick and substantial relief of withdrawal symptoms and cravings. For example, methadone combined with slow-release oral morphine. Community clinics that provide opiate agonist treatment should have on-site access to wraparound services, that is primary care, mental health services, and case management. And now I'd like to discuss briefly safer supply programs. In these programs, hydromorphone tablets are dispensed to high-risk opiate users, sometimes in combination with opiate agonist treatment. Several studies have found that these programs are associated with a reduced risk of overdose. However, safer supply has not been directly compared to opiate agonist treatment with respect to overdose rates or rates of injection-related infections. The programs typically dispense hydromorphone tablets as a take-home medication. Patients are sometimes prescribed 30 to 40 tablets per day to take home. Safer supply patients can sell these tablets, which is called diversion, or they can inject them. Diversion of take-home hydromorphone tablets appears to be common based on clinicians' reports from patients and families, media reports, and qualitative studies. Diversion has been a major factor in other drug epidemics, including the OxyContin epidemic of the 90s and early 2000s. Reports indicate that hydromorphone tablets are being sold not just to people who use fentanyl, but to youth and to people on opiate agonist therapy. Hydromorphone tablets are very inexpensive, and even high school children can afford them. Criminal gangs are clearly involved, and these tablets are now being sold in remote communities. Researchers in Canada have not looked at the harms of diversion of take-home hydromorphone tablets, but earlier research have found that youth who used diverted prescription opiate tablets were at higher risk for subsequently injecting the tablets and higher risk for switching to heroin. I personally have had patients who switch from diverted hydromorphone tablets to fentanyl. Fentanyl is also inexpensive, and it produces a more sustained euphoria and withdrawal relief than the tablets. Unsupervised injection of hydromorphone tablets is also a serious problem. Evidence indicates that injection of prescription opiates increases the risk of life-threatening bacterial infections such as endocarditis. There are several practical and evidence-based strategies that safer supply programs can undertake to improve the safety of their programs for patients and the public. One strategy is to dispense hydromorphone tablets under supervision. Research has shown that supervised dispensing of opiate agonist medications markedly reduces the harms of diversion and unsupervised injection while having minimal impact on treatment retention rates. Another strategy is to combine hydromorphone with optimal doses of opiate agonist medications. Opiate agonist medications are long-acting and thus more effective at relieving withdrawal symptoms than hydromorphone tablets. OAT will also reduce the need to prescribe large numbers of hydromorphone tablets.
Dr. Kahan.
I'm sorry, your time is up, Dr. Kahan. I'm sorry, your time is up. If you could just finish your sentence, but your time is up.
Sorry. Okay. I'm basically done. Thank you very much.
So, Dr. Nutsky.
In St. Paul's Hospital, Canfar Chair in HIV/AIDS Research at the Faculty of Health Sciences at Simon Fraser University. I'm also senior author on a study evaluating BC's risk mitigation guidance, what I'll call RMG, and what was later termed Prescribed Safer Supply, which was published in the British Medical Journal in January of this year. I'll focus my opening statement on this study as I know it's of interest to this committee. The study was conducted at a true provincial scale.
Dr. Nozick, il n'y a pas de...
I'm sorry, there's no interpretation.
Sorry, can you repeat that?
Il n'y avait pas d'interprétation.
No, there wasn't any interpretation, but the problem has been resolved. Thank you. So you can go ahead. Thank you.
Are we ready? Yeah. Good morning. Thank you for the invitation to attend this meeting. My name is Boran Nosik, and I'm a professor in St. Paul's Hospital, Canfar Chair in HIV/AIDS Research at the Faculty of Health Sciences at Simon Fraser University. I'm also senior author on a study evaluating BC's risk mitigation guidance, what I'll call RMG, and which was later termed Prescribed Safer Supply, and which was published in the British Medical Journal in January of this year. I'll focus my opening statement on this study as I know it's of interest to this committee. This study was conducted at a true provincial scale using BC's linked health administrative data sets. My research team has specialized in the use of these data over the past 17 years and has been supporting the province's response to the overdose crisis since its declaration. In its first 18 months, just under 6,000 of the estimated 250,000 opioid and psychostimulant users in British Columbia accessed the program. These 6,000 included just over 5,000 people with an opioid use disorder, of whom we estimate there are over 100,000 in British Columbia. Those accessing the program tended to have long histories of substance use disorders, were socially marginalized, and were at high risk of overdose death. As the program was designed to reduce the risk of overdose and death among recipients, we focused on these outcomes to determine whether the initiative had its desired effect. We otherwise focused on the immediate effects of RMG dispensations, given the fact that, like birth control pills or insulin for diabetes or even opioid agonist treatment, their effects should only be expected to persist while in use. As the guidance was issued provincially and on an emergency basis at the onset of the COVID-19 pandemic, a randomized control trial was not possible. As such, a population-based study using extensive linked health administrative data represents the best possible study design. Moreover, we executed the study to the highest possible methodological standard. As noted, it was recently published in one of the highest impact medical journals. The intended mechanism of the RMG program was to separate individuals from the toxic illicit drug supply. Our findings suggest this mechanism was realized. People had lower risk of death while they were receiving RMG dispensations, and more frequent receipt was associated with a stronger protective effect. That's a crucial piece of evidence. It's what we call a dose-response effect, and it's one of the key conditions that we look for in a causal effect in epidemiology. These effects were independent of any concurrent opioid agonist treatment prescription or other potential confounding factors that were apparent at baseline or which may have changed over the course of time after individuals initiated RMG. These effects otherwise held true whether we consider drug-related or all-cause mortality, and we found comparable effects for stimulant RMG dispensations, though far fewer people received them, and so there was a greater degree of uncertainty in these findings. The risk mitigation guidance has been a controversial program, drawing criticism within BC and across Canada since its implementation, long before our study's publication. Scholarly debate, that is debate based not on ideology or anecdote, but on scientific evidence, is a useful and constructive part of the decision-making process. In that spirit, our team systematically and with additional analysis and evidence addressed each of the critiques we received after our study was released via a public presentation delivered on February 7th, which has been posted online. I've made this presentation and all other peer-reviewed articles and reports that I'll be referring to available to the committee. I think we need some time for the French translation to come through. To summarize, our study demonstrated that for the relatively few people who were able to access it, the RMG program or prescribed safer supply saved lives. Moving forward, we hope these facts and the lives of some of the most vulnerable Canadians are sufficiently considered and will inform debate and decisions about this intervention, one of a continuum of different services that we require to address the opioid crisis. Thank you.
Merci, Dr. Nozick.
Thank you very much, Dr. Nozick. Now, 5 minutes. Dr. Goyer, over to you. Hello.
Of myself in English, but my talk in French. I'm happy to take questions in English or French, whatever works best. So first, thank you for having me here. Thank you also in the name of my patients who are dying very regularly. I'm happy to see that we are all on the same boat together now, trying to find solutions together. Very important for me and my patients. I'm an old addiction doctor now. I've been doing that for 20 years as an in- and outpatient doctor. I have a master in public health and a certificate in added competence in addiction medicine. I am the chief of addiction and homelessness medical services in downtown Montreal. and I've been working for many years now in a low threshold opioid use disorder clinic. So I'm a OAT prescriber, I'm a safer supply prescriber, and also I am the director of the ESCODI team, which would resemble maybe of what you know about BCCSU or Metaphy in Ontario. What we do in my team is offer clinical tools and build guidelines for the whole Quebec province. I'm also a co-searcher for CRISM, and I have the chance to work abroad with doctors of the world to help implementing OAT in low-threshold countries. Ce que je souhaite vous dire aujourd'hui est...
Today, I would like to deal with two topics that are very much related. First of all, as a doctor, I'd like to be clear on diagnosis before treatment. And currently in 2024, there is a contamination of the illegal supply, and the problems are related to illegal consumption and the contamination of the illegal market. I would like you to see the image of an iceberg in your head, and so there are different levels of rates of death, and we know that we have to underscore the problems, but we must not hesitate to act. We have to go forward with things that work, access to treatment, and drugs like methadone, or treatments and approaches like safer supply. We could talk about we don't really do safer supply. We do medical prescriptions based on the decisions of clinicians in a clinic, from experts. And what works? Supervised injection, supervised consumption material, naloxone, drug analysis and checking. And we have to have these services now everywhere. And in 2024, it's not normal that most addicts do not have access to treatments. And in most prisons in the province, there is not access to this kind of treatment. And this is a failure of Canadian medicine if we are not able to provide these services, and including Naloxone. That's the top of the iceberg. But what's hiding below the surface? My colleague, Dr. Nishka, said, who are the ones dying from drug abuse? And it's the social determinants of health that we have to take into account. We have a health system which is not very accessible and not really universal. We are in an upside-down health system. The sickest people, those that have the most health problems, that have the greatest needs, that are homeless, First Nations, those should be the first ones to have access to these integrated and comprehensive services. And we will have to ask ourselves the question, and why is that not the case now, given the crisis that we're facing? It's the problem of stigmatization of these users, and also there has to be a framework of public policies and services. We have to be creative, innovative, and we have to reimagine public health policies. We have to decriminalize. We have to ensure that the conditions that have led to this crisis do not continue, and that drug users are not still marginalized. And so, above all, we have to deal with and provide services for those who are the most vulnerable. Thank you very much. Thank you very much, Dr. Noyes. So I'm going to suspend. This is for the witnesses. We're going to suspend about 20-25 minutes so that MPs will be able to go to I think we have a quorum again, so I think we'll begin the meeting again. And, Mr. Kitchen should be arriving soon. It's been more than 25 minutes that we've been suspended. So first question before continuing, do colleagues, and then I'll ask the witnesses as well, are colleagues willing to continue to at most 1 hour, 1:30? Great, thank you very much. And witnesses, will you be able to stay with us till 1:30 so that we can have our dialogue with you? Is that okay? Great. So I have a third question. And if the regular chair does not arrive in time, will you allow me to ask questions as well? Thank you very much. So we'll continue. So first of all, first round of 6 minutes, starting with Ms. Goodrich. Thank you very much, Chair. Thank you to our witnesses.
It's a really important subject, as you guys all know, and I've got a few questions. Just to, at the end of this, we're hopefully going to have a report, and in the report we'll have a series of recommendations, and I truly think it's important to make sure that we're looking at action as we're moving forward through this. And so I guess I will start out. Dr. Kahan, you talked about the importance of OAT therapies in addiction treatment, and I was just wondering if you could expand a little bit on Alberta's model when it comes to the virtual opioid dependency program, how that works and how you think that could possibly be spread across the country.
Yes, I think the Alberta model has been highly successful. I mean, they are starting thousands of people in the same day on opiate agonist treatment, and that includes people in remote communities, people who have attended emergency departments or hospitals. And this is the way to do it. Canada is such a dispersed, geographically distant communities. We need to get OAT to where people are, in their communities, in the hospital, in the emergency departments. And virtual care is an efficient way to do it. They have 24/7 services, I understand it. It's not just virtual care. They have connections to prescribers, nurse practitioners, and physicians, as well as to pharmacies. So I think it's a very good model to make sure that people in remote communities and people who have lack of transportation, people who are in hospitals and emergency departments have access to care.
Thank you for that. I know I did a tour recently of the Calgary Arrest Processing Center with the Calgary City Police, and they actually had the ability to offer people that were recently arrested the access into the VOPD program right from the Arrest Processing Center, and were telling me some of the successes they had, which is a really cool build-out. Dr. Goyi, vous avez parlé aussi.
Dr. Goyi, you also talked about the therapies like OAT.
What you see in some of the shortfalls in accessing OATs across the country, and how you would increase people's access to OAT therapy.
Merci pour la question.
Thank you very much for the questions. I think that basically you have to define the priority in the context of a chronic illness. It's a bit complex, but things like diabetes and cardiac problems, they offer us examples of professionalization and training for healthcare workers. And I said in my presentation, we're far from having the system that we need, and I think that there should be compulsory training in all medicine schools of medicine, so not just for doctors but also for pharmacists, nurses, and monitors and employees of social assistance groups. And I think there is a certain ethical responsibility. And if I see you with a heart attack in the emergency room, and I'm going to give you an electric shock and send you back to your home without any medication, without follow-up, I would lose my doctor's license. And that's what happens, however, with drug dependency. You go to the emergency room with overdose, you just get a Naloxone, and then sent home. You get you should have specialists that will be able to come to provide advice, continuing and follow-up care, and that we have to ensure adequate follow-up. Unfortunately, we don't have very much time, so I'm going to go to my other questions. Sorry.
Nosky, is that how you say it? Nosik. Sorry. What are the barriers to getting OAT in Ontario? I know just in anecdotal conversations that I've had, people talk about the issue with the actual payment of how expensive OAT therapies are. Is that an issue in Ontario?
Well, I'm from BC.
Oh, sorry.
Right.
Then BC.
We've expanded
Apologies.
access to OAT enormously over the past 10, 15 years. And that has been, getting more doctors on board, reducing the restrictions, the requirements for licensing to get doctors to be able to prescribe OAT, and more patients have accessed it. We hear of constraints to access still in rural regions. I think it's, a symptom of our constraints in primary care provision. We have a shortage in primary care, and I think this population is severely affected. Payment, much of the payment that goes into OAT goes into the pharmacies, right? Direct witness ingestion fees and
Finissez votre phrase, Dr.
dispensation fees.
Nozick, il reste plus de temps.
Okay.
Ça va?
That was
Okay.
it. I finished, yeah.
Alors, Monsieur Jory, pour 6.
Mr. Jury.
Well, I'd like to welcome all our witnesses. I'm going to start with Dr. Elaine Hishka. Dr. Hishka, in your opening remark, you talked about the shift in drug supply. And I just wanted to get clarification from you and probably a little bit of expansion. So the shift in the drug supply is as an independent phenomena, or is as a phenomena as a result of, let's say, access to safe supply might not be as readily available? And whether this shift is only unique to Alberta, or have you seen it across Canada?
Thank you for the question. So in my opening remarks, I refer to the staggering difference we see between 2011 and 2023, when in 2011, at the height of the prescription opioid crisis, when as many as 1 in 5 Canadians were reporting using a medical-grade opioid, according to some surveys, we had 91 Albertans die of drug poisoning death, and that was primarily opioids. Now, obviously, the numbers are astronomically higher than that. And so what really we started to see around 2012, when there was a series of very well-intended measures to limit access to prescription opioids at a population level, we saw a very dramatic decline in population flow of prescription opioids that were either being prescribed to patients or being diverted and sold in legal market. In Edmonton, where I'm from, when I was doing my research, epidemiological surveys back in 2012, my PhD research, everyone I talked to that was using opioids was using either hydromorphine pills that had been purchased or prescribed to them. Now, though that's virtually unheard of, we see so few people using those medications now. Everybody is using fentanyl. And what we believe has happened, according to the evidence we can piece together, is that the decline in the prescribing of opioids corresponded with a fundamental shift in the illegal market towards novel synthetic opioids. So basically, we cracked down on prescribing, but we did not address demand. And as a result, the illegal market innovated. And now we have fentanyl's analogs, carfentanil, nitazene class opioids, fake benzodiazepines, and a whole host of other very dangerous drugs that are the primary drugs circulating in the opioid supply, and is contributing to a staggering amount of death that we have not seen before. And this trend is something we're seeing across Canada, in particular in BC, and later, but now quite clearly in Ontario and other parts of the country.
So this phenomena is going across Canada. Okay, thank you on that. So now I understand that current available treatment option is an area that you've been looking into, and you've been doing some research, and in that and a safer supply. Can you shed some light around how these available treatment options, along with a safer supply, will be able to help present an alternative to the situation that we are, the dilemma that we are facing with?
Yeah, so I think I echo everybody on the panel that it is critical we respond with with a wide variety of different opioid agonist medications and options for people, and that we need to dramatically expand access to those medications as first-line treatment for opioid use disorder. But we also know that there is some patients for which those medications are either not an option or not something, or something they've tried and has not been successful for them. And I don't think it's okay to just say, well, I'm sorry, that's all we've got for you. I think it is reasonable to prescribe people prescription opioid medications in an attempt to stabilize them and to support them and to reduce their extreme risk of overdose death from consuming fentanyl and other toxic street drugs. So I don't think that these are opposing things. I think we absolutely need on-demand treatment, high-quality evidence-based treatment using the full range of modalities, including injectable opioid agonist treatment, which really has not been expanded at all in our country. But that being said, there will be people that, for whatever reason, those medications are not an option or have not worked for them, and we can't abandon that population. We really need to support everybody we can to stay alive. It's just not acceptable to have this level of death in our country for something that is ultimately preventable.
So last question coming to you is, you also, in your opening remarks, you talked about the societal response that we need to present, and also talked about some of the wraparound services. You got about a minute. Can you clearly expand on that? I know you went into a number of action items. What would be the top 3 societal response that would be able to address the issue that we are facing? Thank you.
Okay, we need to treat this like an actual public health emergency. We need to invest at the scale to ensure that the effective treatments we have, like opioid agonist treatment, supervised consumption services, naloxone, that's actually meeting population need. I would say that there's a lack of investment in these interventions to the point where they're not scaled to meet the need in the population. Beyond that, I think we need to look at the factors that drive drug poisoning death, which are increasingly housing, poverty, and comorbid mental health conditions. For example, in my home province right now, about 40% of drug poisoning deaths, just under, are occurring in public places, which is implying that that's a lot of people who are unstably housed or homeless that are currently dying as a result of drugs, obviously, but also the fact that they're rendered so precarious in these situations of being unhoused and having no support. So I think primarily the federal government really needs to step up the level of investment in services across the country in partnership with provinces, because we have just not scaled our response anywhere where it needs to be to bring down and achieve sustained reductions in morbidity and mortality across the country.
Thank you very much, Mr. Johari. Monsieur Thériault, vous avez la parole pour 6 minutes.
Mr. Thériault, it's over to you. Thank you very much. Thank you to the witnesses for their presentations. I'm going to start with Dr. Goyer. Dr. Goyer, you said that that we were faced with a crisis of a contamination of the illegal drug supply, and you stressed this problem. And what do you think about this problem? Could you develop it a little more? Yes, well, in fact, I think that the facts, the information that we've collected, and I think if we really want to have a public health response that is adequate, we have to decide what is the real problem. And I think in Canada and North America, we've also talked about overprescribing, but right now, what we faced with now is that there are mostly deaths caused by illicit drugs on the illegal market, not by prescription drugs. And of course, we have to ask ourselves, what can we do? And I would like to warn you against the fact that as a doctor, like we've heard from the others, we have to really do more, but we can't take all the responsibility, for example, for the illicit drug supply, because a lot of those people will never have access to treatment. Either they don't need it, they're not dependent, they don't want any treatment, or they're just recreational users. So we have very few doctors in Canada. A first-line doctor that's aware of the problems, who could be there and who might be able to prescribe treatments and is aware of what can be done. So we have to have more types of availability of these services. So we have to ask ourselves why there's so many people who are dependent on drugs, and what can we do to address problems like poverty and childhood traumas, health problems, mental health problems. And then secondly, how will we deal with the illicit market? How will we counter the illegal market? And how will we use science and our experience with alcohol, tobacco, and recently cannabis to inform our efforts in prioritizing the fight against illegal drugs, the illegal drug supply. So in a previous meeting, some witnesses told us that the fourth pillar of the intervention and the application of the law and fighting organized crime will not have a great deal of effect, and they said that there could be a need for more drastic measures, for example, the legalization. And when you say that the safe prescribing is not efficient or sufficient, and the safer supply and safe injection sites are not sufficient and are not sufficient to deal with an incredible public health crisis, I can tell you that this is a very complex and a difficult problem. There can be no single solution. We have seen that the existing responses are not widespread enough. And I think we have to spend money, train health professionals. I'm going to repeat that we're in an opioid crisis, and we should come out of medical school, or we don't now have doctors coming out of medical school and they don't know anything about dealing with addiction. And I don't understand how doctors are not trained in something that they're very much going to need. And I think that, as I said, with regard to the iceberg, the below the surface, we can see that we've spent huge sums to fight drug trafficking, and we're still losing the battle. And I'm not a specialist in public policies, but I think we have to do things differently and creatively. Sorry, there are people who say that since safe supply can lead to redistribution of these drugs, and that's a problem. It's not really a problem of the untrained doctors, but they feel that the supply doesn't really go to the people who need it. You're asking me a number of questions, but I'm going to try to answer very quickly. There are a number of false premises with regard to a safe supply. First thing is that there are very few doctors that do this type of thing. So if you want to really have a safe supply as an effective measure, we have to do that as well with treatment. We have to do a lot more safe supply and have a lot more people capable of offering safe supply. And there are examples of legalization in Canada that we could look at, but we have to remember that we are criminalizing hyper-vulnerable people who are sent to prisons and who have mental health problems and housing problems, and we continue to make their life precarious. And so, sorry, I'm sorry, but your time is up. Thank you very much. Thank you very much, Mr. Theriault.
You have the floor for 6 minutes. Thank you.
Thank you, Mr. Chair, and I want to thank all of the witnesses for their important testimony and for the work they do. Dr. Hyshka, you talked about the need for the federal government to declare a national public health emergency, something that the NDP has also been calling for. And we saw the federal government recently, they just hosted a summit on auto theft. But they haven't done anything like that on this crisis. And you talked about you've lost more lives in Alberta due to the toxic drug crisis than you did to COVID. Yet we saw the spending and the effort from the federal government is less than 1% of what they've spent in terms of responding to the toxic drug crisis than they have COVID. Do you believe the federal government is doing enough in terms of rolling out a plan with a timeline and resources? And what do you believe is necessary to respond to this crisis in the short term?
Yeah, I don't want to get bogged down in debates over the specific legal mechanisms of declaring an emergency or not, but I think obviously we need to recognize this for what it is, a public health emergency, and we need to substantially increase federal spending. And I think we also need to not only do that, but look at currently 60%, almost 60% of federal spending for the Controlled Drug and Substances Strategy is going towards law enforcement efforts. And I think we need to be looking to see if that is getting us the best value for money in terms of improved population health outcomes. We are not resourcing enough provincially or federally, social programs, healthcare, and a whole host of other options that can potentially be more effective at supporting people to stay alive and achieve recovery and get well. Beyond that, I think in the short term, there's a lot of things the federal government could do immediately to try to bring down the death rate. First and foremost, please do not cut the existing funding to safer supply programs. We know from evidence from different treatment studies as well as emerging safer supply evidence that if you abruptly cut people off their prescription medications, they're at a much higher risk of death. So just sustaining that funding, continuing to innovate in that area to look for more effective solutions, including non-prescriber models of safer supply. We just had a study published on the Compassion Club in BC that showed very early but promising results in terms of reducing mortality. Beyond that, I think we could be looking to improve safer supply programs by working with pharmaceutical companies and regulators to identify medications that are going to more effectively meet people's needs, potentially reducing the risk for diversion. Beyond that, I think we really need to look at a national project around decriminalization. You know, I can't think of a stronger form of stigma than criminalizing someone. And we talk a lot about needing to end stigma, but then we continue to criminalize people for their health conditions. In BC, there is a imperfect decriminalization pilot happening. I think we need to have a national conversation about what this would look like across the country. And we need to first and foremost and permanently say this is a health issue. We need to stop criminalizing people, and that needs to happen across the country. It's not fair that people who use drugs in BC are potentially not subject to criminal charges, but everywhere else they are. I would also like to see an overhaul of the SUAP program. I think the way that the investments are currently made is not as effective as it could be. And I think we need to be looking at ongoing operational funding for evidence-based services as part of a core suite of options for people across the country. And I think federal funding could play a huge role in ensuring equitable access to treatment across the provinces, equitable access to safer consumption services, and other really proven interventions. I also want to highlight too, and I'm not sure the committee has heard this evidence, but we know in Alberta that and BC that the majority of people who die from drug poisoning are dying after smoking drugs. And yet supervised consumption services across the country, very few of them actually allow people to smoke drugs within them. And so a pretty quick change that could happen is for the federal government to subsidize supervised consumption services to make the renovations required to be able to accommodate supervised inhalation. And I think that would have an ancillary benefit of bringing more of the public drug drug use that is a concern across the country due to a whole host of factors, including a lack of housing. But it would bring that public drug use inside. And certainly this is a big issue in Edmonton, where I'm from. Many people are smoking drugs outside of supervised consumption sites because they cannot smoke them inside. And if they go down and have an overdose, they know the staff will run outside to help them. That's not an effective way to respond to a crisis. And it's something that could be addressed pretty quickly in the short term. And I think it would save lives.
Let's dive into Alberta. Much has been made of the Alberta model oriented on recovery and treatment. However, recent data highlighted that overdose rates in Alberta are rising fast since it was put in place, much faster than in British Columbia. Maybe you can talk about why do you think that is? You got about 60 seconds to do that.
Sure. I think it's always a result of multiple factors when we're looking at trends in drug poisoning. Some things we're seeing in our province that are concerning. There's been a substantial reduction in the number of people using supervised consumption sites. It's about half of what it was before the pandemic. And I think it is because of the lack of incorporating inhalation, as well as a number of closures and relocations of the services that have disrupted connections to care for people who use drugs. We are also, like I mentioned, seeing a lot more deaths in public spaces. We need to be addressing homelessness and unstable housing. I think if people had safe places to live with proper services and wraparound care, they wouldn't be dying of drug overdose on our streets. Beyond that, we have relatively low rates of opioid agonist treatment coverage for a province of our size. Only about 14,000 Albertans in Q3 of 2023 were being dispensed opioid agonist medications. That just seems to be quite a low coverage rate. And so I think we need to also do more to expand access to opioid agonist treatments in our province. And of course, I don't know why Alberta hasn't moved to trial safer supply. It is potentially a very powerful tool, as Dr. Nozick spoke to reduce mortality amongst a subset of people who use substances. And we need to use every single tool we have to address this generational and staggering crisis.
Thank you very much, Mr. Johns, Dr. Hishka. We'll turn now to Dr. Kitchen. Dr. Kitchen, you have the floor for 5 minutes, please.
Thank you, Mr. Chair, and thank you all for being here. And sorry, unfortunately, you had to do with the protocol of the House here and interruptions, et cetera. But I appreciate you all. In your opening presentations, you all made some significant points that I think that we all wanted to hear. And, Dr. Goyer, you talked about something that I agree with 100%, which is diagnosis first, and then you lead to the treatment. And I appreciate that comment because I think it needs to resonate a lot more with people. Ultimately, I think what we're looking here is how do we need to be recovery oriented. And I think that's being missed. That recovery orientation needs to be one of the biggest focuses that we have. And I come from Saskatchewan. I come from a very rural area. And I mean, I have with me basically the the OAT standards from the College of Pharmacy Professionals, as well as basically a map of what's going on in Saskatchewan right now in where doctors are even trained to do it. And that's a huge aspect of how do we make certain that we have that access to these rural areas, because the focus apparently to me that I see is the big cities and not rural Canada, and that's important. Dr. Kahan, you sort of talked a little bit about rural areas, and I'm wondering if you could comment on basically when we look at best practices, things that we need to look at. Is it valuable to be putting in safe supply, or more so for an OAT program? I'm wondering if you could have some comments on that.
I think that it's unfortunate that there's been this binary discussion, safe supply or no safe supply. Mm-hmm. I don't think that that's what the focus should be. I think the focus should be on ensuring that safe supply is actually safe for individual patients and the public. And this idea of prescribing large numbers of take-home tablets is actually harming people. It's leading to unnecessary and deadly bacterial infections, and it's leading to diversion, which increases use of hydromorphone and then ultimately fentanyl among youth and among people on OAT and other problems. This can be practically and feasibly made safer by having hydromorphone tablets. The issue is not hydromorphone versus methadone. The issue is take-home versus not take-home. And if you allow take-home and people who are clearly involved in the drug trade, you're going to have diversion and it's going to harm people. So have supervised hydromorphone, supervised methadone, supervised injection opiate agonist therapy. That's what's needed. In terms of rural communities, it really is a very bad situation. At least in Ontario, some of the OAT providers are these large corporate chains that do not provide high quality care. Even physicians that want to do good care have limited access to case management and mental health resources. And some rural communities have no OAT at all. And some pharmacies neglect or refuse to dispense OAT. That is a problem, and I think it's very unfortunate that SUAP has put all their resources into safer supply, yes, and other initiatives while downplaying opiate agonist treatment. And I think that needs to be changed. There needs to be a balanced approach.
Thank you. I appreciate that. And I do appreciate how you, in your presentation, you've been very clear and educative in your presentation as well, because you've talked in language that Canadians can listen to, as opposed to the researchers. And that's what I think people that are watching this meeting want to hear. They want to hear it in their language, not in researchers or technology. And while I may understand it, there are others who don't. And so I appreciate those comments. You know, one of the things that was brought up in our last meeting was on talking about the issues of dealing with pain and what I learned back many years ago was 3 steps dealing with basically pharma, psychology, and physical. And those 3 aspects need to be addressed when dealing with patients. And so I'm wondering, Dr. Goyer, if you would, on that point, if you could maybe, I realize you have very little time, but if your thoughts along those lines, please.
When we want to deal with complex problems like dependency or pain, of course, there can be a place for pharmacology, but there have to be complex responses to complex situations. So you have to have a wraparound care for dependency and for clinical treatment. And I think that the pharmacological approach is one thing. You can offer therapies, ensure access to psychological services, and also have multidisciplinary teams.
I'd like to move a motion as amended.
Sure, go ahead, Dr. Kitchen.
So I'd like to move a motion that the committee invite the Minister of Health and the Minister of Mental Health and Addictions to appear each for 1-hour meeting on the Supplementary Estimate C for the fiscal year 2023-2024, and that the ministers appear before the end of the current supply period, March 26, 2024.
Thank you very much.
So is that the motion that was put on notice?
Dr. Ellis's motion as amended.
Amended to add.
Just give us the motion. So, colleagues, the difficulty, of course, was that since I'm sitting here, I was the one who moved the motion. It makes it incredibly difficult for that to continue. Colleagues, we all know that the bells are ringing at the current time. In order to continue this committee, we would need unanimous consent to do so. My concern, of course, is if we do not do that, that will effectively be the end of the meeting, given the amount of time to get to the chamber vote and then come back. So I am at your service as the chair of the committee. Is that the will of the committee to continue? Yes. Very well. Thank you, witnesses, for understanding that there is a bit of machinery in motion here. So appreciate that. So just so everyone's clear, the bells are ringing in the House. There will be a vote after that. I suspect that that will probably be the end of the meeting with respect to timing, but we'll see when that comes. And at this moment, then, Madame Brière, vous avez la parole pour... No, I already said no. Madame Brière, vous avez la parole pour 5 minutes.
Madame Brière, you have the floor. 6 minutes.
Very well, Dr. Kitchen.
I believe I think if you canvass the room, you would see that there's unanimous consent to make that amendment.
That's fine. Colleagues, I think you heard Dr. Kitchen's amendment. The problem, of course, is that I had moved the motion originally, and if there's unanimous consent, we can obviously be the masters of our own destiny, and if there is, I see heads nodding. Yes, there is unanimous consent. Very well. Thank you, Dr. Kitchen. Great. Après ça, Madame Brière, vous avez la parole.
Now, Madame Brière, you have 5 minutes. Thank you.
I'm a very bad chair, obviously, and I apologize for that because we didn't vote on it. We moved it and then didn't vote on it. So, see, there's a lot of machinery on the go. Yes, very well. So the clerk has an excellent suggestion. If Dr. Kitchen, if you could reread the motion, that would be very helpful.
Thank you. That the committee invite the Minister of Health and the Minister of Mental Health and Addictions to appear each for a 1-hour meeting on the supplementary estimate C for the fiscal year 2023-2024, and that the ministers appear before the end of the current supply period, March 26, 2024.
So we've all heard the text of the motion, and it appears to be in order since we've had unanimous consent to move that. Do we have consent around the table that this is appropriate at the current time? It looks like we have consent. Great. Okay, motion adopted. Thank you very much. Now that I've finally got all that out of the way, we can move back to the original business. And pour la troisième fois, Madame Brière, vous...
And for the third time, Madame Brière, you have 5 minutes. Thank you very much for your patience.
Merci beaucoup à tous.
Thank you very much to our witnesses, Dr. Goyer. We've heard that in the testimony that diversion is because of unsatisfied demand. And what are the reasons for this type of diversion? And does that have any effect on the list of medications paid for by the public health system? So I'm going to come back to the meaning of diversion because and the aspect for diagnosis and treatment. And if you prescribe in safe supply, there will people say that there will automatically be a diversion. I would say there are very few safe supply programs and very little supervised prescription. And I think this goes back to the issue of the stigma associated with safe supply, whereas there is a great deal of prescription, great deal of variety. There are people that go off with a month's supply for pain and things like that. So the situation is not very clear for me. And I also think that there is some prejudice associated with this idea that drug addicts would automatically try to resell any drugs they might get. And secondly, as for the drug users, often there is not enough treatment available, and the drug addicts try to help each other. And when they're in withdrawal, or when they don't have access to drugs, or when the pharmacy is closed, remember that many pharmacies refuse as well to provide opioid treatments or drugs. And I think this is one of the situations there can be diversion. And the idea where it can then be offered to children. I think that it's very dangerous to take political decisions on fear rather than on science and on reality. But if there is a great deal of diversion, who are these children and what are we afraid of? We're afraid of death for these children, or that they might become drug addicts themselves. So what can we do with children who take opioids and die? They have died, though, from illegal contaminated drug supplies. There's just been a child who died in Quebec recently who thought he was just taking a X drug, and in fact there was a very deadly substance that he took. So there are no real prescription drugs that are in the hands of young people. And who are the people who sell to children? And they don't have prescribed drugs. If they don't have prescribed drugs, they sell, in fact, illegal drugs. And so for me, it just comes back to the same two questions. What are we going to do with our illegal drug supply? That's the problem right now that is causing these deaths. And the second question is, how can we ensure that that there was diversion to children, if that really existed? How can we decide or know who becomes dependent? It's not the recreational users, it's the people who are in fertile ground based on traumatisms, health problems, mental health problems, poverty, access to housing. We always come back to the same facts. And so let's try and find a treatment that targets the illegal market and the social determinants of health. That would be my response. Thank you very much. My next question with regard to the recreational drug users. We've also heard last Monday that from the opposition that you use safe supply and that type of treatment. Do you think there are doctors who would prescribe fentanyl to people who are not already dependent on possibly contaminated drugs or unsure drugs? Sorry, Dr. Goyer, can you possibly provide that reply in writing and send it to us if possible?
Le temps c'est fini.
We don't have any more time for you to answer. Would it be possible? Would it be possible for you to send your response by in writing? Thank you very much.
Obviously wasn't here during the last vote. My question to you now is there is 15 minutes that exist before the time to vote is. The question is I understand last time you left here with 10 minutes left. Is that still the will of what people want to do? I see general agreement. Great. That will give us 2.5 minutes each from Mr. Thériault and Mr. Johns. Mr. Thériault, vous avez la parole pour 2 minutes et demie.
Merci.
Mr. Thériault, over to you. Thank you very much. If I can sum up. So we find ourselves faced with a crisis of illicit drug supply, contaminated drugs, an unprecedented crisis. And as we've seen, not far from us, there have been overdoses, deaths, and Dr. Goyer, you said that we can see that those who die, I mean, what you said earlier were those who are the most vulnerable, who are facing other crises as well. And so we have to deal with the social determinants of health. This is a reality, a cultural reality. And then there's the illegal market. And there's, I think we're not doing enough to fight the illegal market. But if we try to look at the resources, and if there's an unprecedented public health crisis, I think we have to go where the people are, and I think we have to multiply interventions in the field where they are. The multidisciplinary team must go where the problems are and where the people are, and not just waiting for people to come to the doctor and get treated. What do you think? I quite agree. What you're talking about is the principle of a study. You have to identify the population that you want to identify. Where are they? What are their needs? And how can we reduce all the barriers to them getting to the health system? And you said you have to go out, you have to be outreach, go to meet the people, work with community organizations that know this clientele well. But that means there are so many obstacles, geographic obstacles and financial obstacles, and what's covered, what's not covered, what services, and also there are also moral obstacles and the obstacles of stigmatization. Often people feel that they're not welcome or well treated in health services, and we also have to include people who aren't ready to stop taking drugs quickly or even at all. So there are people. Imagine the terrible suffering there would be if people did not have access to drugs to help them deal with their situations and their suffering. So if there are people who are ready to stop using drugs immediately, we can't just talk about them. We have to talk about the whole spectrum of drug users and deal with the problems, drug use and safe supply. All that must exist together. Thank you very much, Goyer. Thank you very much. Thank you, Mr. Thériault.
Dr. Nozick, we've heard many anecdotes about diversion, particularly to children. We haven't heard that from law enforcement. But can you comment on this as someone conducting research in BC on prescribed safer supply?
Sure, thank you. We've heard statements and anecdotes of diversion, yet in British Columbia, opioid use disorder incidences remain constant since 2020, since the Safer Supply program was implemented. And that's true for those under 19 and overall. Moreover, and I want to stress this again, hydromorphone was detected in just 3% of all overdose-related deaths in 2022, albeit as one component of a number of substances implicated in toxicology rather than the primary drug implicated in the overdose. On the other hand, fentanyl was implicated in over 80% of all overdose deaths, most commonly the primary substance indicated in toxicology reports. Make no mistake, the overdose crisis in BC is driven by fentanyl and its increasingly potent analogs.
How widely has Safer Supply been implemented in British Columbia? And it often seems from the media on this that it's a huge problem, but really is it? And has there been enough capacity? And you're going to have about a minute left of this whole meeting to respond.
No, it was the implementation was very limited. A lot of prescribers chose not to prescribe, and many of those who did chose to add it on to OAT as opposed to offering it as a distinct option. It was primarily prescribers located in Vancouver and Victoria who prescribed these RMG medications, at least in the first 18 months. These prescribers serve larger and more severe caseloads of people with substance use disorders. Nurse prescribers participated as well. Prescribers with a background in psychiatry were less likely to participate. And already by the end of our study period, by August 2021, we saw prescription start to dissipate. Our qualitative research, and I'll highlight that I work with a range of investigators from UVic and the BC Centre for Disease Control. A qualitative study from our team highlighted barriers to access in rural regions, criminalization, and indication that the substances prescribed in many cases were insufficient and didn't entirely eliminate reliance on the drug supply.
Thank you, Mr. Johns. Colleagues, we are at the time as we suggested. I would suggest that if we went and voted and came back, we would probably run out of time. Is it the will of the room to adjourn the meeting? And if that would be the will, then great, and if not, please let me know. I see, is there a motion there?
I think that you know my preference, Mr. Chair, that we
I
try to...
do not actually, so...
So I'll help you. I would hope that we could vote from here and keep going. This is an important study, and we could run right till 1:30, and we could try to get a lot of questions in on these very important witnesses.
So in order to do that, we would need unanimous consent, and I do not believe we do that. Do have unanimous consent.
Have you asked for that?
I've heard no's already.
From who?
Well, I don't think I need to tell you, but I've heard it, yes. Yep, so Mr. Kitchen's going to exercise his vote, his will to vote in person. So, colleagues, as I said, with someone going to vote in person, I would suggest to you that we will not have time to come back after that and have more testimony from the witnesses. Yep. So, do we have a motion to adjourn? We have a motion to adjourn from Mr. Kitchen. Do we see consent around the room to adjourn the meeting?
No.
No.
Okay, well, we don't have consensus to do that either. Very well. Should we suspend the meeting?
We can do a recorded division.
Gotta have time to get to the chair,
Yes, you do.
so we've got to suspend now.
Yep.
So we can go to a recorded division for the motion to adjourn, or we can suspend.
Yep. Meeting adjourned.